Med-Surg chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I would like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. This chapter is Chapter 51 from Davis Advantage Medical Surgical for registered nursing, coordinating care for patients with burns. This time I decided to use just my concept map. I'm not gonna do no Zoom, no other type of slides. I'm gonna talk through this only this slide. And this chapter, I find out that many students have a very hard time to understand this chapter. It took me a while to make this concept map. I used smart art in Microsoft Word. So this is my PowerPoint slides that I use, and it took me a while, but I think it's pretty. So this chapter, it has introduction, incidents and epidemiology, pathophysiology, systemic effects of major burn injuries, special consideration in patients with burns, palliative care and other conditions treated in a burn center. So in the introduction, it says about the 30 key terms which are critical to the chapter. I posted already in nursing terminology. So they have like allograft, autograft, burn shock, contracture, eschartomy, full thickness burn, lumped and Borner, myoglobulia, rule of nines, total body surface area, which is TBSA, xenograft and zone of burn injury, which is coagulation, hyperemia, and status. We need to know the book has a case study. It talks about 40-year-old patient with 22 pounds, so it's about 100 kilograms. Injuries, it's burned to the face, anterior trunk and bilateral upper extremities sustained while throwing gasoline on a bushfire, on a brush fire. Initial signs, so thickened nasal hairs, think about, is very important, this key, and carbonaceous sputum, but not difficulty swallowing or breathing reported. Initial status, placed on 100% oxygen with 2 large bore peripheral IV catheter. So the introduction, here, let's go one by one. Emphasize that patients with burns are optimally managed at the burn center by an interprofessional team. Notes the limited number of verified burn centers into United States. Stresses the necessity for non-specialized healthcare provider to understand stabilization and initial management before transfer. The key point is introduces the American Burn Association Burn Center referral criteria. Like for instance, for partial thickness burns, the TBSA is the total body surface area. Burns involving the face, hands, feet, genitalia, major joints, full thickness burns, and inhalation electrical, chemical injuries. The next, incidents and epidemiology. We have the burn center referral criteria. It's a box 51.1. Purpose is to ensure patients with high risk burns receive specialized interprofessional care. The key criterion example, burns involving the face, hands, feet, genitalia, perineum, or major joints, all full thickness burns in any age group, or partial thickness burns 10% TBSA or greater. So the spatial causes also applies to electrical, chemical, and inhalation injuries, as well as burns with concomitant trauma. Fire statistic and death, they have a magnitude in 2021 over 1.35 million fires were reported in the United States. Impact, those fires resulted in 3,800 civilian deaths and 14,700 civilian injuries. And the leading causes, meaning the epidemiology, two most common reported causes for burns center admission are fire, flame, 40.6%, and scald injuries, 31.4%. Age-specific causes, scald injuries are most prevalent in children under age of 5, while fire, flame dominates all other age group. The high-risk demographics, age, older adults age around 65 or greater have 2.5 times higher risk of dying in a fire than population as a whole. The sex, men account for nearly 68% of all burn center admission, likely due to greater risk taking behavior and high-risk occupations. Prevention focus. So burn prevention strategies focus on high-risk groups like children and older adults. Home safety example, installing and maintaining working smoke and carbon monoxide detectors, and setting the water heater temperature no higher than 120 Fahrenheit, so it's about 48.9 Celsius. 3. Pathophysiology. We are in pathophysiology. This section explains how burn injuries are classified and how they affect the body at the cellular level. A classification by death, so it's a modern terminology. The traditional first, second, and third degree system is replaced by deep classification to better describe tissue damage. Superficial burns affect only the epidermis, like sunburn, and heal very quickly. Partial thickness burns extend to the dermis, often painful with blisters. Deep partial thickness burns take longer to heal and risk conversion to full thickness. Full thickness burn destroy the entire epidermis, and dermis are insensate, no pain in the center. And why? Because the nerve it's damaged, so that's why, and will not heal without skin grafting. And then they have a type of grafting: allograft, autograft. Total body surface area, the TBSA, Estimation is crucial for determining the need for fluid resuscitation. Required for adults 20% TBSA or greater. Three common estimation methods are the rule of palm, approximative 1% TBSA, the rule of nines, common in pre-hospital care, and the more accurate age-adjusted Lund and broader classification used in burn centers. So keep in mind the rule of palm, rule of nines, London burner classification. So this is used in burn center. The three centric zones of injuries. They have so they are localized tissue damage described by three zones radiating from the heat source. Zone of coagulation, the central area of irreversible tissue death. A scar is present and nerve endings are destroyed. Zone of stasis surrounds the central zone. This area has impaired circulation and is most susceptible to becoming deeper, converting to coagulation if fluid resuscitation is inadequate. Zone of hyperemia, the outermost area marked by increased blood flow and minimal injury, typically recover within 1 to 2 weeks. We have a systemic response trigger. The systemic response trigger burns less than 20% TBSA typically produces only a localized tissue response. Burns 20% TBSA or greater are considered major burns injuries and trigger a systemic inflammatory response affecting all body system, leading to conditions like burn, shock, and hypermetabolism. Electrical injuries, as the Grand Massacre, the extent of damage from electrical injuries is often not apparent on the skin surface. Contact points. Electricity follows the path of least resistance, causing deep muscle, nerve, and bone damage that is often more severe than the surface wound. Deep muscle damage releases myoglobin into the bloodstream, myoglobinuria, which can occlude renal tubules and cause acute tubular necrosis, so kidney failure. Once again, the pathophysiology, we have the classification, the burn etiology, the thermal, electrical, chemical, and radiation. The burn depth, superficial partial thickness, deep partial thickness, fluid thickness, total body surface area percentage, rule of palm, rule of nines, London border classification, severity, inhalation injury, age, past medical history, location, anatomical changes, concentric zones of burn injury, zone of coagulation, zone of stasis, zone of hyperemia, functional changes, risk of long-term morbidity in functional areas like face, hands, feet, major joints. We move to systemic effects of major burn injuries, and then we go by the systemic here. We start with respiratory, which it's inhalation injuries, carbon monoxide poisoning. It's high morbidity risk. Inhalation injury significantly increase morbidity and mortality. Airway edema, thermal injuries often cause rapid swelling in the upper way above the glottis, requiring emergent intubation. So think thermal injuries often cause rapid swelling in the upper airway above the glottis, require emergent intubation. Chemical versus thermal. Burns below the glottis are usually chemical in nature from smoke toxins. Carbon monoxide poisoning, CO, is highly toxic. Pulse oximetry is unreliable because it cannot distinguish CO from oxygen. Treatment for CO, patient must be immediately placed on 100% oxygen to decrease the high life of CO in the blood. So basically I'll tell you 5 things that I found very important for each of them. So next, 5 key points for cardiovascular burn shock. For this, to keep in mind, cardiovascular burn shock, distributive and hypovolemic. Burn shock type, the patient develops a combination of hypovolemic and distribute shock. Capillary leak, a massive increase in capillary permeability causes fluid plasma protein to leak out of the blood vessel and into the tissues, is the third spacing. Hemodynamic changes, this fluid shift leads to decreased cardiac output, hypotension, and increased blood viscosity. Peak fluid shift, fluid leak typically peaks around 24 hours post-injuries, post-shock diuresis. Once capillary integrity is restored, usually after 48 hours, fluid shifts back into blood vessel, leading to significant diuresis, increased urination. Fluid and electrolytes here. We have initial hyperkalemia, release of potassium from damaged cells into bloodstream, causes initial hyperkalemia, dangerously high potassium. Subsequent shift, as fluid is lost to third spacing, the patient may later develop hypokalemia and hyponatremia. Fluid loss source, electrolyte and fluid losses occur through third spacing and significant evaporative loss through the open wound, which can be up to 5 liters per day. Metabolic acidosis, loss of bicarbonate ions contributes to metabolic acidosis. Number 5 for this, monitoring close and replacement of all electrolytes are essential due to those massive shifts. Renal, impaired perfusion, Decreased circulating blood volume from burn shock leads to decreased renal perfusion, myoglobinuria risk, muscle damage, especially from electrical injuries, releases myoglobin into the bloodstream, acute tubular necrosis. Myoglobin can occult renal tubules, potentially causing acute tubular necrosis, kidney failure. Urine output target. For patients with myoglobinuria, the target urine output must be increased up to 1 ml per kilogram per hour to help clear the toxin. Diuretics contraindicated. Diuretics are not indicated in the emergent phase. If urine output drops, the rate of IV fluid administration might be increased. Gastrointestinal mobility decreases. The patient stays in bed, right? Major burns cause a decrease in both nutrient absorption and gastrointestinal motility. NG tube propers. An NG gastric tube is often placed to relieve gastric distension and for long-term feeding access. Abdominal compartment syndrome. Patient requires massive fluid resuscitation, are at risk for developing abdominal compartment syndrome due to extreme edema. Stress ulcer prophylaxis. Patients with large burns receive GI prophylactic medication to prevent stress ulcers, Corling's ulcer. Lastly, because I have 5 key points important for each, the 5 is early internal nutrition. The early initiation of internal nutrition, tube feeding, is vital for improved outcome and reducing stress ulcer. We have metabolic. The hypermetabolic state, the burn induces a prolonged hypermetabolic and catabolic state that can last 1 to 3 years. Increase energy needs, the metabolic rate may double, requiring a significantly increased caloric intake. Nutritional support. Nutritional support. Without aggressive nutritional support, wound healing is impaired and the patient suffers muscle catabolism, breakdown. Impaired thermoregulation, loss of skin integrity leads to massive heat loss through open wounds. Warming measures. High ambient temperature in the patient room are essential to prevent life-threatening hypothermia. Immunological. 5 key points are barrier loss. The loss of skin barrier markers the patient highly vulnerable to infection. Altered defense. Burn injuries severely alter the patient's immune defenses. Systemic inflammatory response syndrome, SIRS. All patients with extensive burns exhibit some form of systemic inflammatory response syndrome, which is an exaggerated inflammatory response. Precursor to sepsis may precede the development of sepsis and requires careful monitoring. Focus, its infection control is a high priority, requiring specialized isolation and meticulous hand washing. Lastly, we have sepsis, leading cause of death. If the patient survived the initial 24 hours of burn shock, sepsis is the leading cause of death. Antibiotics not prophylactic. Prophylactic antibiotics are not recommended due to the risk of breeding antibiotic-resistant pathogen. Burn-specific definition, general definition of sepsis are not entirely applicable to burn patients as their baseline inflammatory state already mimics some septic criteria. Trigger sepsis is triggered by a change in the patient along with other specific clinical manifestation. High fever, progressive tachycardia, hyperglycemia. Mortality, the mortality rate of sepsis in burn patients can be as high as 65%. We move to 5 special consideration in patients with burns. It is crucial section that details the life-threatening pathological changes that occur when a burn exceeds 20% of TBSA. We have a burn shock, distributive and hypovolemic. The primary imminent threat is burn shock, which is a combination of hypovolemic, low volume, and distributive fluid misplaced shock. This is caused by a massive fluid shift out of a blood vessel into the tissue, the third spacing, due to increased capillary permeability. The result is a decreased cardiac output, hypotension, and increased blood viscosity, thicknesses. We have respiratory compromise and carbon monoxide poisoning. Upper way edema can develop rapidly. But here we have inhalation injuries, which is the carbon monoxide, electrical, it's like contact points, cardiac monitoring, myoglobulia management. So in upper airway edema can develop rapidly, necessitating emergent intubation to maintain a patient airway, a patent airway. Carbon monoxide, the CO poisoning is common in life training because CO, so carbon monoxide, binds to hemoglobin 200 times greater than oxygen, causing tissue hypoxia. Pulse oximetry is unreliable with CO poisoning, requiring treatment with 100% oxygen until CO levels drop. The hypermetabolic and catabolic state, a major burn triggers a prolonged hypermetabolic state, often doubling the patient's normal energy expenditure. The state persists for 1 to 3 years and requires aggressive early internal nutrition to prevent catabolism, muscle breakdown, and support healing. Massive amounts of body heat are lost through open wounds, necessitating increased ambient temperature to prevent hypothermia. Electrolytes imbalance and renal risk. Initial hyperkalemia is common due to the release of potassium from damaged cells. A fluid shift continues. Sodium and potassium are lost to the third spacing, which can lead to a subsequent hyperkalemia and hyponatremia. Myoglobin in the urine, often seen in electrical injuries, risk acute tubular necrosis, ATN, if fluid resuscitation is inadequate, requiring a high target urine output. I think I review here now. So the sepsis is the leading cause, the late death, the loss of skin barrier, the impaired immunological defenses place the patient at risk for infection. All major burn patients develop systemic inflammatory response syndrome, an exaggerated inflammatory state. If the patient survived the initial 24 hours of burn shock, I said earlier, sepsis is the leading cause and requires specialized criteria. So now actually we're moving special consideration. So kind of we talk about this, but kind of getting in these two. In inhalation injuries, the diagnostic challenge, a normal chest X-ray on admission is common. Fiber optic bronchoscopy is recommended for a definitive diagnosis. Excuse me. Insidious onset, it's a respiratory distress, rarely presents immediately patients. Patient must be observed closely for 24 hours for subtle signs. Signs like hoarseness or anxiety and confusion. Airway management, if airway patency is questionable, early intubation is recommended to prevent severe airway obstruction from edema. Secure endotracheal tubes must be secure with twill or commercial holders, not adhesive tape, because tape will not stick to the edematous or burn phase. Carbon monoxide treatment, patient receive 100% oxygen until carboxyhemoglobin levels are below 10%. In electrical injuries, 5 key points is the grand massacre. The injury extent is not apparent on the skin surface. Contact points, deep muscle, nerve, and bone damage is extensive. Cardiac risk, which is continuous cardiac monitoring for 24 to 48 hours is required. due to the risk for dysrhythmias or cardiac arrest. Myoglobinuria is a muscle damage, releases myoglobin, which risk acute tubular necrosis. Renal gall urine output must be maintained at 1 ml per kilogram per hour until the urine clears of myoglobin. Trauma consideration, the patient should be placed in a cervical collar until the cervical spine films are clear due to potential associated trauma. Example, form fall. Chemical injuries. 5 key points are primary intervention, immediate and continuous irrigation with copious water of water is crucial initial treatment. For the chemical injuries, it's immediate irrigation, acids, alkalis, organic compounds. Alkali versus acid. Alkali burns are most destructive because they cause liquefaction necrosis, leading to deeper tissue penetration. Neutralizing avoided. Neutralizers avoided. The use of neutralizing agents is generally not recommended because the chemical reaction may be exothermic, like heat producing, and worsens the injury. Systemic absorption. Organic compounds like gasoline can be systematically absorbed, leading to severe renal and hepatic damage. Staff safety. All healthcare team members must be wear appropriate personal protective equipment, PPE, to prevent secondary injury or contamination. We have here, very hard for me to pronounce, eschorotomies and fasciotomies. Here we have the compartment syndrome. Any circumferential burn is a high risk for developing compartment syndrome as swelling is confined by inelastic tissue. HR tourniquet. In full thickness circumferential burns, the scar acts as a tourniquet, which can compromise circulation to the extremity. Assessment. Hourly neurovascular check like pulse, color, sensation are mandatory. Eschorotomy procedure is a surgical incision through the eschar. Is performed often at the bedside to relieve pressure and restore distal circulation. Fasciotomy procedure. It's a deeper surgical incision extending throughout the muscle fascia, is performed usually in the operating room for deep muscle swelling, most often electrical injuries. The interprofessional management of burn injuries, we have in the emergent phase, which is medical management priorities is airway management, airflow 100% oxygen is administered, early intubation is done if inhalation injury is suspected. Fluid resuscitation, lactate ringer, LR, is the fluid of choice initiated for adults with 20% TBSA or greater burns using 2 to 4 ml per kilogram per percent TBSA formula. Prevent hypothermia. So hypothermia is a constant risk. The patient must be covered at all times. The room ambient temperature is increased. Pain management, IV narcotics are the preferred route. The IM is the intramuscular route is avoided due to poor absorption in the edematous tissue. It's burns. You cannot use it, right? Diagnostic studies, it's AKG and troponin are required for electrical injuries, carboxyhemoglobin, it's measured for inhalation injuries. Nursing management priority, assess airway, monitor for signs of inhalation injury, example, carbonaceous sputum, hoarseness, stridor, hourly. Monitor fluid adequacy, titrate IV fluid to maintain urine output at 0.5 ml per kilogram per hour or 1 ml per kilogram per hour if myoglobin is present. Vascular access, insert 2 large bore peripheral IVs and secure them well due to massive edema. Circulation checks, perform hourly neurovascular check on all extremities, especially with circumferential burns. Secure endotracheal tubes, secure the tubes with a twill or commercial holder, not a tape. Intermediate phase here. Medical management priorities, wound closure, early excision and grafting, decrease hospital stay. Autograft, it's the patient on skin, is the permanent coverage. Wound care, daily wound cleansing involves hydrotherapy using a clean technique, not sterile, and topical antimicrobials. Pain management, medication are transitioned from IV to oral and given on a scheduled basis to manage pain, background procedure or breakthrough. Nutrition support, early internal nutrition to feeding. It started quickly for 20% TBSA or greater. Burns to combat the hypermetabolic state. Infection control, sepsis is the leading cause of death for after the emergent phase. Prophylactic antibiotics are not recommended. Nursing management priorities, time pain management, wound care, monitor for nutritional status, mobility, and assess for infection. So let's start with pain medication. Administer procedural medication to reach peak effectiveness during dressing changes and physical therapy. For wound care, meticulously rub each finger and toe individually to prevent webbing and maintain function. To monitor nutritional status, monitor daily weight, caloric intake, and serum protein albumin levels. Mobility actively assist with ADL, which is the daily living, and encourage self-care and compliance to rehabilitation exercise. Assess for infection, monitor for systemic signs, example, changes in temperature, mental status, fluid needs for evidence of sepsis. For here, rehabilitative phase, medical management priorities, care management, fit patient for custom pressure garments to be worn 23 hours a day to prevent hypertrophic scarring. Contracture prevention, physical and occupational therapy begins immediately with splinting and positioning to maintain range of motion. Psychological support address long-term emotional consequences such as PTSD, body image disorder, anxiety, and depression. Reconstructive surgery plan for potential multiple reconstructive surgical procedure. Discharge planning ensure a seamless transition home with community resources and outpatient therapy services. Nursing management priorities assess compliance, assess patient compliance with splitting, pressure, garments, and daily home exercise regimens. Mobility and function encourage and assist with ADL to increase independence and prevent impaired physical mobility. Psychosocial check assess readiness for social integration and monitor for signs of disturbed body image or depression. Patient education teach the patient and family about burn prevention, sun protection, and the long-term healing process. Pain management, continue to manage chronic pain, especially neuropathic pain, to facilitate participation in physical therapy. Here for palliative care, primary role, the core function is to minimize suffering and provide close family support throughout the patient's care journey. Beyond end of care life, consultation is appropriate not only for end of life care but also for patients having extra difficulty managing pain and anxiety. Also aids for decision making. The team helps patients, family members, and the care team navigate complex decision making process. Social and complex care, palliative care is also valuable for patients with difficult social situation or those require coordination by multiple medical teams. Early involvement, it is recommended that palliative care should be routinely uh, contacted and involved early on in the management of critical injured burn patient. Lastly, other conditions treated in a burn center. This section covers non-burn conditions like Stevens-Jones syndrome and toxic epidermal necrosis that are treated in burn center due to their severity. The causes, etiology. This condition is most triggered by an adverse medication reaction, for example, to sulfa drugs or anticonvulsants, or viral infection or reaction to a toxin. Damage, pathology. The skin's top layer, epidermis, separates the slough, peels off, from the layer beneath it, creating large open wounds that looks very like a major burn. Classification: the condition is classified by how much skin is involved. In Stevens-Jones, it's less than 30% TBSA, slogging, while in toxic epidermal necrolysis is greater than 30% TBSA, slogging. The mucosal involvement, in addition to the skin slogging, affects the wet surfaces throughout the body, includes the eye, mouth, GI tract, and urethra, making it extremely dangerous. Reason for burn centers care: um, toxic epidermal has a very high mortality rate, up to 80%, mostly from septicemia, which is a blood infection. This requires the burn centers specialized expertise in expert wound care, fluid management, and strict infection control. This section also outlines conditions beyond typical thermal, electrical, or chemical injuries that are often managed in specialized burn centers. The 5 key points from this is: expand scope of care. Burn center manage a variety of conditions that involve the integumentary system, underlying soft tissue and muscle, not just traditional burn injuries. Other treated conditions include necrotis fasciitis, frostbite, and bullous pegmoid. But Stevens-Jones and toxic epidermal are commonly caused by an adverse medication reaction, viral infection, or reaction to staphylococcal toxin. The pathophysiology, both are characterized by epidermis separating and slogging from the dermal layer, a process that can also affect the oral mucosa, conjunctiva, vaginal canal, gastrointestinal, urethral linings. Classification by TBSA: the distinguish between the Stevens-Jones and the TEN is based on amount of body surface area, TBSA. For Stevens-Jones, it's less than 30%, while the other one involves greater than 30%. Critical airway management for Stevens-Jones, and for the toxin epidermal. An immediate concern is airway protection due to oral lesions and slogging, which may necessitate emergent endotracheal intubation. The toxic epidermal also carries a high morbidity rate, 25 to 80%, usually due to septicemia and multiple organ dysfunction. So here, based on this section, also condition other than typical thermal, electrical, or chemical burns that are managed. I said frostbite, scleroderma, calciphylaxis, necrotizing fasciitis, bulbous pemphigoid, staphylococcal, scalded skin syndrome, purpura fulminans, and erythema multiforme. So those conditions are managed in a burn center because involve the integumentary system, underlying tissue, soft tissue, and or the muscle, often requiring the specialized wound care, infection control, electrolyte management, and rehabilitation expertise to the burn team. Now let's make a little recap. So this chapter covers several important labs and diagnostic studies, primarily for the emergent, which is the resuscitative phase of burn management. The key labs and diagnostic you should know. Initial laboratory studies, those are essential for establishing a baseline, determining resuscitation needs, and identifying pre-existing conditions like complex metabolic panel used to monitor fluid and electrolytes, especially initial hyperkalemia for cell damage and later hyponatremia, hypokalemia from fluid shift, includes keratin and bone for renal function. Complex blood count, CBC, used to assess overall status. Note that initial elevate hematocrit is common due to fluid loss, concentration. Coagulation studies, PT, INR, baseline to assess clotting ability, toxicology screen, and serum glucose baseline assessment. Surveillance culture to be taken later for definitive diagnosis for sepsis or infection. So injury-specific diagnostics, certain injuries require immediate specializing tests like carboxy hemoglobin level, crucial for patient with suspected inhalation injury like fire in an enclosed space to diagnose carbon monoxide poisoning. Electrocardiogram, baseline test for all patients, but continuous monitoring for 24 to 48 hours is mandatory for electrical injuries to detect dysrhythmias. Troponin and CKMB levels obtained for electrical injuries to detect damage to the cardiac muscle. Urinalysis for myoglobinuria, essential for electrical injuries and any extensive muscle damage, as myoglobin in the urine can lead to acute tubular necrosis. confirmatory and imaging. It's chest ray, obtained initially but often appears normal in the early stages of inhalation injuries. Fiber optic bronchoscopy, the recommended procedure for a definitive diagnostics of inhalation injuries because it can directly visualize damage to the respiratory tract. Now let's elaborate on a target lab values used to monitor fluid resuscitation, such as heart rate or urine output. That's a critical area of a burn care. Monitoring for adequate fluid resuscitation is primarily done by observing those psychological parameters and lab values, which are key indicators of tissue perfusion. Indicators of adequate fluid resuscitation monitoring paramedics. Monitoring for adequate fluid resuscitation is done by observing the following psychosocial parameters, which are key indicators of tissue perfusion. Urine output, most reliable. Target 0.5 ml per kilogram per hour adults. Critical action. The nurse should immediately notify the healthcare provider if hourly urine is below 30 ml in a patient with large burn injury. Target for myoglobin 1 ml per hour, 1 ml per kilogram per hour if myoglobin is present, common in electrical injury. Maintain its higher output until the urine clears to prevent acute renal failure. Heart rate target less than 120 beats per minute. Rationale is that tachycardia can indicate persistent hypovolemia or shock. Systolic blood pressure target is greater than 100. Rationale is that necessary to maintain adequate perfusion, tissue perfusion. Central venous pressure, CVP, target is 5 to 10. Level of consciousness, LOC, clear, alert, and orientate. Is deterioration may indicate hypoperfusion or hypoxia. The ABLS fluid resuscitation formula is this calculation determines the total volume of lactate reger here is. So the lactate reger solution, the LR, needed in 24 hours post-burn. This general formula is total volume equal milliliters factor times weight in kilograms times percentage of TBSA burn. We have here the ml factor using calculation depends of patient category. 2 ml for adults 15 years or greater, 3 ml for children 14 years or younger, 4 ml for all ages in electrical injuries due to extensive internal damage. Fluid admission schedule, the total calculated for the first 24 hours is administered in 2 time segments. First half 50% given the first 8 hours from time of injury, second half 50%, given over the next 16 hours following the first 8 hours. Important timing, the 8-hour and 16-hour period are calculated from the exact time the burn injury occurred, not the time the patient arrived at the hospital. In here, the example calculation using the example from the chapter, patient weight 70 kilograms, TBSA burn 50% flame burn, adult factor 2 ml, total 24. You can see here the calculation. So burn fluid resuscitation monitoring and calculation protocols, indicators of adequate fluid resuscitation. Monitoring adequate fluid resuscitation is done by observing the following psychological parameters, which are key indicators of tissue perfusion. Urine output, most reliable target value 0.5 ml per kilogram per hour. Critical action point, the nurse should immediately notify the healthcare providers if hourly urine output is below 30. We said that, right? And lastly, the pathophysiology and clarification. Let's revise. Superficial burns are excluded from resuscitation. Only partial thickness and full thickness burns are counted when calculating the total body surface area for fluid resuscitation. Zone of status risk, the zone status area surrounding the most damaged tissue, is the most susceptible to inadequate fluid resuscitation, which can lead to limited blood flow and conversion to a deeper, more severe burn. Full thickness, appearance, and pain. A full thickness burn, third degree, it's characterized by dry, leathery, insensate, no pain. Tissue called eschar because all nerve endings in the dermis are destroyed. Burn center referral criteria, burns requiring transfer. For partial thickness burn, full thickness burns of any size, and burns involving the face, hands, feet, genitalia, perineum, or major joints. Inhalation and electrical injuries, airway, priority of inhalation. Airway maintenance due to rapid onset of laryngeal edema. For electrical injury monitoring, patients with electrical injuries require continuous cardiac monitoring for 24 to 48 hours and monitoring the myoglobinuria, the T-color urine, to prevent acute tubular necrosis. Chemical burn intervention. The primary and immediate treatment for chemical burn is continuous irrigation with copious amounts of water. Alkali burns tends to penetrate deepest and require the longest irrigation. Complication in intermediate phase compartment syndrome intervention, the escherotomy, the surgical, and then leading cause of death post-emergent, after the emergent phase infection leading to sepsis. So then leads to death. So sepsis is often indicated by a temperature greater than 102.2 degrees Fahrenheit and progressive tachycardia. Immediate phase focus management shift to wound closure autograft is the ideal permanent cover, and ensuring optional nutrition. Early NG tube is highly recommended due to hypermetabolic state. So we know in emergent phase and resuscitation, the fluid of choice is LR, right? The urine output, it's 0.5 ml per kilogram per hour. So I think that's it is for this. Keep in mind that burns are classified by the cause of injury, the depth of the tissue damage, and the total body surface area involved in the burn. So the four categories are used to define the depth of skin and underlying tissue damage: superficial, superficial partial thickness, deep partial thickness, and full thickness. This chapter is very complicated, but I hope I made it simple for you to understand. And thank you for listening to me and just seeing just one page. But this, I think, will help you to kind of have a not glass, glance of the chapter, how the chapter is like, and what it's about burns. Thank you for listening to me, and I see you in the NCLEX for this chapter. Bye for now.
We finally made it!
Thank you again for your time and trust. I'm Mia, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.